So Javier has the full merit of the previous lecture. I only inserted the boomerang, nothing more than the boomerang. So now we continue to speak about the ankle. Specifically, we'll address the lateral area, the lateral aspect of the joint for ligaments. We have a list of ligaments to check, and all of them are really important. And in general, even if we have a patient with a lateral ankle sprain, then it's important not to limit the examination strictly to the series of ankle ligaments, but we also have to spend some seconds more to check the metatarsal ones. You know that lateral ankle sprains are a very common occurrence in sport medicine. Is a very common injury, especially in the emergency department. And typically the mechanism is an inversion and plantar flexion of the foot. And different from the knee, ultrasound has a great role to image the ligaments in the ankle. It may manage the problem without asking help to MRI. It's important to consider that at the ankle level, the association of intraarticular lesion to a lateral ligamentous injury is not as common as in the knee, and so there is no need to go on with the other imaging modalities like MRI unless you have a persistent pain, persistent effusion at the level of the tibio-talar joint. Remember that timing of ultrasound is also important. In general, in the very acute setting, ultrasound tends to overestimate the severity of the injury. Anyway, the technique has a really great role to check the status of all of these ligaments. And first of all, the anterior talofibular ligament, the most commonly injured, because it's the weakest and is also very exposed to injury. Its main role is to restrain anterior talar motion. Is part of the capsule, so the ligament in itself is not separated from the capsule. It's a capsular reinforcement, and it has to be considered as such. It attaches to the lateral malleolus, as you can see here, and then to the talar neck in this area. And deep to it, we have a recess of the joint, the anterolateral recess, the anterolateral gutter, and where we can see some effusion. Is very often seen here. This is the point of is the first point of joint distension. But when we see this kind of effusion and there is nothing at the level of the anterior recess of the tibio-talar joint, remember that this effusion has to be considered completely normal. So when you examine this ligament with ultrasound, it's important to remember that ligaments like tendons are fibular structure, and if the beam is not perfectly perpendicular to them, they may appear echoic. This is related to anisotropy in many cases, but a hypoechoic appearance of ligaments may be also related to a grade 1 sprain. So be very careful when you scan this ligament to tilt the probe as much as possible to make the ligament as perpendicular as possible to reduce any anisotropic artifacts. This may help to separate what is artifact from a minor sprain injury. So this is a sprain of the anterior talofibular ligament. So this is the shape of the ligament. You see is very wide here, but based on some anatomical studies, this is one published on an anatomical journal. The ligament in itself can be subdivided in two separate bands. superior and inferior. No, in many cases these bands are totally separated. So there is the capsule in between them, but they can be appreciated as two different fibrillar structure. And this is not a variant. This is 95% of cases. The point is that when we place the probe here in the long axis of the upper part of the ligament, we are happy. And we don't spend more time to go more inferiorly to check the second part of the ligament, because the second part of the ligament can be seen very often. Look at this video clip. This is the upper part, this one, and then I going down, and this is the lower part. So in some instances, the upper part, that is the most biomechanically exposed, may be ruptured. No? And when it's ruptured, you have a break in the capsule, and the fluid located at the level of the joint migrates up to into the soft tissues here, superficial to the ligament. Then you go down and you see the inferior part of the ligament, very thickened, but not completely torn. This is the transverse image, the short axis image of the two components, one absent, the other one very thickened inferiorly. So remember this point is maybe important to sweep the probe up and down and to be sure that to have a full depiction of the two components. In many cases you can see this kind of picture. Don't stop when you see the interruption, especially when you have a minimal instability. Go down and you will see that in many cases the other part will be thickened but not completely interrupted. So in children and adolescents, you know, the way ligaments tear is a bit different from adults, and this is because the bone is immature. And similar to some apophyseal injuries, even when we go to scan the ATFL in children, not uncommonly as a result of a trauma or some sporting activity, you can see that the problem is not related to the mid-substance of the ligament, but is related to its attachment into bone. And you can see different pictures. In some instances, you can have a double cortical line related to the avulsion of the most superficial layer of the cortex. In general, this occurs at the level of the lateral malleolus and not at the level of the distal insertion, because this is the most biomechanically exposed area. Remember that in many cases, especially if the trauma occurred earlier, you can have also the avulsion and the fragmentation of the cartilage when the lateral malleolus is not really ossified but is still chondral. The repeated attraction may create some fragmentation of the cartilage, and the cartilage then ossified with time, producing some ossicles within the ligament. This is the reason for which, not uncommonly, when we scan adult patients, we demonstrate pictures like this one, in which the ligament may be more or less normal, but anyway not really torn. And within the substance of the ligament we demonstrate ossicles. And they appear not as avulsions, but just ossicles. One typical example is the os subfibulare, that is clearly and very commonly recognized on radiography. And in these cases, the ossicle derive from old avulsion injuries in the children age group, with some migration of the cartilage, some disruption of the cartilage at the level of the attachment, and then ossification of it, forming fragments. In the adult population, we don't have problems affecting the bony attachments, but the mid-substance of the ligament. And you know that in these cases the ATFL is the first to tear. It's with the progressive load, the second ligament in general involved is the calcaneofibular ligament, and the involvement of the posterior ligaments, specifically the posterior talofibular ligament, is really involved in a minority of cases. And this is good for us, good for ultrasound, because ultrasound is able to see something about this ligament, the level of the insertion of the posterior talofibular ligament. There is also some literature about, but is not able to assess the status of this ligament. But if it's less than 10% involved, this is not a great problem for ultrasound. In case we have a complete tear of the ligament, as I said before, you can have a full thickness disruption of the ligament substance and passage of fluid from the tibiotalar joint outside into the subcutaneous tissues. Remember the sonographic anterior drawer test, inviting the patient to lie down on the bed, blocking the knee on the bed, and then pushing the foot, the forefoot towards the floor while in inversion position. This kind of maneuver may be helpful because it may, in doubtful cases, it may better clarify if there is a discontinuity in the ligament substance or not, and it also help to demonstrate the instability, the talar shifts relative to the lateral malleolus. So you can exert much more force in this position than with the foot flush on the table. The second ligament to check is the calcaneofibular ligament. This may be part of the standardized technique, so you cannot miss it. It's much stronger than the anterior talofibular ligament, and it joins the posterior aspect of the lateral malleolus and a tubercle on the lateral aspect of the calcaneus. So it's this is the profile, the long axis view of the ligament in a cadaveric picture, and this is the position of the peroneus longus and the peroneus brevis. As you can see in this image, when the ligament is elongated in its long axis, we are in the short axis of the peroneals. If we place the probe in the long axis of the peroneals, the ligament is in the short axis. No? The problem related to this ligament is that the mid-distal part is nicely seen on ultrasound because it's very well exposed. The ligament is more or less perpendicular to the beam, but the proximal part no, because the ligament becomes oblique and the orientation of these fibers is not really clear. It cannot be addressed in many cases. So this is the typical occurrence. You place the probe in the long axis of the calcaneofibular. You see a very heterogeneous distal ligament. No? You see the peroneals here. You check all the structure Javier described it before. And how is the ligament here? Which is the status of the fibers here? Not really easy to assess on ultrasound unless you invite the patient to dorsiflect the ankle. And when you dorsiflect the ankle, the ligament becomes trite. It pushes the peroneals up, and this sign may help the diagnosis. So don't forget that this ligament has to be evaluated anytime in dorsiflexion. So if this is the ligament in a neutral position relative to the two peroneal tendons, in a dorsiflexion, this is what happens. The two peroneal tendons are displaced superficially by the intact ligament. And we can use this kind of sign, this is a dynamic sign, to assess if the ligament is interrupted, is discontinuous, or is abnormal but still continuous. So this is a video clip showing the calcaneofibular ligament in neutral and then in dorsiflexion. You see the ligament becomes tense, it elevates from the bony surface, and it pushes the peroneals more superficially. So this is the proof that the ligament is healthy or is not discontinuous. This is another example, a patient with a very thickened and hypoechoic ligament, but is the ligament completely interrupted or not? In this case, you see that during dorsiflexion, the peroneals remain deep in the groove. They are not displaced by the ligament, and this sign indicates ligament discontinuity. So at the same time, when we have a ligament discontinuity, remember that the calcaneofibular is just a thickening of the capsule, is part of the capsule, like the anterior talofibular ligament. And when the calcaneofibular ligament is torn, you have a break in the capsule, and soon superficial to the capsule, we have the parietal sheath of the peroneal tenosynovial envelope. No, and so when we have a tear in the ligament, we have discontinuity of the capsule, and 100% of cases there is a break also in the adjacent sheath of the peroneals, with the passage of joint fluid from the joint space into the sheath of the peroneals. So when we have this kind of picture, check the peroneal systematically, and not uncommonly you can see some effusion distending the peroneals in at the level of the retromalleolar and inframalleolar groove. And this fluid is not related to tenosynovitis. Peroneals may remain completely normal, but it's related to the passage of joint fluid into the sheath. So what is that? This is the Titanic going down, sinking in the ocean. No, why the Titanic? No, this is due to my child. No, because my child wants to build up Titanic by Lego. No, and then he goes to the pool. No, and anytime we have to try a way to see the Titanic sinking in the pool, no, but it's not easy with the Lego. We have to fill it with coins, with metal, with other things, because but the Titanic now is useful to understand the technique we have to use to demonstrate the anteroinferior talofibular ligament, and specifically this ligament in association with the first of the fascicles that is named the Basset ligament. So the anteroinferior tibiofibular ligament is located more or less here. This is the position of the anterior talofibular ligament. This is the calcaneofibular ligament. No, and the technique to image this ligament is to place the probe at the level of the anterior talofibular ligament, and then to rotate the probe up anteriorly. So the ligament disappears first, and then you pass over the cartilage investing the lateral aspect of the talar dome. As soon as the talar dome disappears, you are at the level of the anteroinferior tibiofibular ligament, and the first fascicle is the Basset. So this is what you should do. This is the ligament disappears, then you see the talus. This is the poop of the Titanic, whoop, going down in the sea, and as soon as the Titanic disappears, I see the ligament, the anteroinferior tibiofibular ligament. No, this ligament is better depicted in dorsiflexion. Remember, because in dorsiflexion there is more pressure between the fibula and tibia to make the ligament in tension. This is very important to remember. But remember the Basset, because the Basset may be involved in the context of the anterolateral impingement syndrome, especially in a patient in which there was some instability of the ankle with previous ligament injuries, no, and chronic unexplained pain, very chronic pain in this area. No, you check the ligaments, is fine. Then you go to analyze the anterior tibiofibular, and you see that the first fascicle of the anterior tibiofibular ligament looks thicker than normal, unexpectedly thicker. No, then you go a bit more distally, and you see this kind of picture. So this is the talar dome, the poop of the Titanic. splenic, no? And you see the cartilage here is normal, no cartilage, cartilage again here. So what is that? This is the result of some scraping exerted by the basset against the cartilage. This is the pathomechanism, no? And this typically occurs when we have instability of the joint and when we have elevation of the, of course, the joint is loaded, no, and so you have some elevation of the dome against the basset. You can see the abnormalities in the cartilage. You can see the thickening of the ligament, and this may explain the condition. Regarding the high ankle sprains, so the involvement of the syndesmosis as a whole, not just the basset fascicle, but also the ligament in itself, the anterior-inferior tibiofibular ligament. Remember that this kind of injuries, in general, derives from the specific biomechanism like a forced external rotation and hyperdorsiflexion. They are common in collision sports, and in general, when this ligament is affected, the outcome is poorer. There may be associated fracture, especially Weber B, Weber C fractures, and there is a chronic ankle dysfunction. This is an example of a rupture of the syndesmosis visible on ultrasound with thickening, discontinuity of the ligament there. Remember that this kind of sprains are also associated with the deltoid ligament injuries, medial malleolus fractures, but are not so uncommon. So it's important not to forget to go up and to check this ligament. This is a nice series published in 2014, in which some athletes with acute ankle sprain were studied with MRI, and from a series of 261 cases, 40% of them had low-grade lateral ligament injuries. Other 40% complete disruption of the ATFL, but 20% syndesmotic injuries, regardless the status of the lateral ligamentous complex. So this means that is not the percentage is really not negligible. Ultrasound can demonstrate this ligament. Remember that deep to it we have the vertical recess of the joint, so some effusion may be seen in some instances, and it doesn't represent a sign of an injury. Remember to perform the examination in dorsiflexion, and when you have you suspect that an injury is present at the level of the syndesmosis, you can also use a dynamic test. This is a very nice dynamic clip provided me by Javier, and you can see the widening of the space here by passing from neutral to external rotation, and this is an example of a complete disruption of the syndesmosis. Then look around, because you can see other findings in cases of a lateral ankle sprain. One of the most common association may be the involvement of the peroneals, no? And Javier already described this kind of condition. This is a nice example of a tear of the extensor retinaculum, of the oblique inferior band of the retinaculum passing over the tendons of the extensor digitorum longus. The patient had a very unstable ankle with rupture of the anterior talofibular ligament and the calcaneofibular ligament, and after the numerous sprains, in the last one there was a disruption of the retinaculum. Probably the retinaculum was something stabilizing laterally in absence of any other ligament, and this is the depiction of the injury of the retinaculum. And then go to the mid-tarsum and check specifically some areas. The most important area is the dorsal aspect of the talonavicular joint, where we have the capsule reinforced by the dorsal talonavicular ligament. You know that when we have an inversion injury, and this injury is associated with a plantar flexion of the foot, you can also apply some force over the dorsal aspect of the talonavicular joint. This may detach a flake of bone from the navicular or the talus, and this is clearly diagnosed on radiography. But in other cases, in other instances, you don't have any fracture. You have a break in the capsule, and similar to what we described at the level of the anterior talofibular ligament, we have a passage of fluid from the talocalcaneonavicular joint into the soft tissues, as you can see here. Another very important ligament, important in terms that is it may be affected, is the dorsal calcaneocuboid. No? And the dorsal calcaneocuboid ligament is one of the most commonly missed fracture at plain film and also at MRI. If you use the usual projections, the usual views for the ankle is really difficult to see. And on MRI you can see something, but not much, and I explain you why. The ligament is very wide. It covers this area, so the lateral aspect of the joint between cuboid and the calcaneus is very broad ligament, and if we have an inversion injury, but the point of application of the force is not at the level of the ankle, but is more anterior, you can have the disruption of the ligament. In general, you have the detachment of a small piece of bone from the calcaneus in continuity with the dorsal calcaneocuboid ligament. If you place the probe transversely, like this one, the flake of bone seems to be microscopic, very small, and then you see the ligament, connected to the fragments. But if you place the probe vertically, you see that the fracture is much wider than expected. In general, it occurs vertically, detaching the most anterolateral, anterolateral angle of the calcaneus. We call it this fracture the match fracture because it's very narrow. So when you perform a transverse planes on MRI, you don't see. You see some edematous changes here, but you don't see the fragment, basically. It may be very difficult diagnosis. And of course, if it's overlooked, in case of a ligament tear, you can also have some chronic instability at the level of the calcaneocuboid joint. Remember that this area is also the area where the extensor digitorum brevis muscle attach to the calcaneus, and so not uncommonly during the sprain, you have some edematous changes and some stretching injury at the level of the overlying muscle. So you can have a ligament injury and an associated muscle injury. Another ligament located in this area, but related not often to lateral ankle, to an inversion injury, but more commonly by impaction during eversion and dorsiflexion of the midfoot, is the bifurcate or the Chopard ligament joining the anterosuperior process of the calcaneus with the cuboid or the navicular. So it is an epsilon ligament, more or less represented here and visible also in these magnetic resonance images. This is an example of a fracture of the anterosuperior process of the calcaneus. Remember that this is another very commonly missed fracture. Because it depends on its visibility, depends on the projection, depends on many technical factors. It may be missed. The patient come to ultrasound due to a chronic pain in this area. You ask the patient, where is pain? There. You place the probe over there and you see the fracture. And you see the fragment is in continuity with the ligament. But remember that the mechanism may be not only related to a stretching trauma, but to a nutcracker mechanism. Then don't forget nerves. I don't know if you already saw some patient with ankle sprains, no? Especially with a history of many ankle sprains, no? And after that, the patient comes to ultrasound room due to the persistent sensory disturbances over the dorsal aspect of the foot. In this case, as soon as the patient says, "Oh, I have some sensory disturbances over the dorsal foot," go up with the probe. Don't study this part. Go up and check the point where the superficial peroneal nerve pierces the fascia. That is much cranial than the level of the ligaments, is approximately 12 centimeter, 10, 12 centimeter above the tip of the lateral malleolus. The ligament pierces the fascia here. In some cases, the ligament divides into the intermediate dorsal cutaneous and the medial dorsal cutaneous, and they pierce the fascia separately, as you can see in this example. And in case you have this kind of picture, you have to check the point where the nerve pierces the fascia, and almost invariably you can demonstrate a fusiform neuroma of the nerve there. Why? Because this is a fixation point, and the nerve is stretched in this area by tension related to the repeated ankle sprains. This is an example in which you see the nerve here, the nerve there, proximal, distal, under the fascia, over the fascia in the subcutaneous. This is the neuroma at the level of the fascial passage. And you can correctly interpret the cause of pain, that is pain or sensory disturbances, that is located much more distally. Moving to the medial aspect of the ankle, we have to address some very complex ligaments, very complex from the anatomical point of view. Maribel gave me this kind of image that is, I think, really fantastic to understand the structure of the deltoid. No, this is a posterior medial view of the ankle, and you see the level of the tibio-talar joint. This is the posterior the dome. This is the level of the subtalar joint, and with the substentaculum tali located here. This is the prominence of the medial malleolus, and in this kind of view, you understand the real structure of the deltoid, that is made of a deep component, multifascicular, as you can see here, and this is the tibio-talar ligament, and superficial to it we have the tibiocalcanear going to connect the medial malleolus with the substentaculum, and then the tibiocalcanear continues more anteriorly in the tibiospring and more anteriorly in the tibionavicular, forming just a continuum, just one structure diverging anteriorly. Okay, so the injury of the deltoid is related to an eversion trauma, in which the foot and heel buckle outwards. And the most important thing to remember when you perform ultrasound is that the ligament is include a lot of fascicles. The tibio-talar, that is the deep fascicle we saw before, joins this part of the medial malleolus with the posterior part of the medial part of the talus, as you can see here. But there is also small fascicles starting from B and going here to insert into the talus again. Much less important, but you can see it. Then we have a tibiocalcanear portion, and the tibiocalcanear portion starts here and connects the medial malleolus with the substentaculum tali. And we have the tibio spring, that is a very special ligament because it joins the medial malleolus and the spring ligament, no? So it connects bone with another ligament. And finally, the tibionavicular, that is the most anterior, connecting B and 5. So one of the typical mistakes one can do is to consider that the deltoid is a triangle, and so you believe that there is a top only just one point of origin of the fibers. This is incorrect because this is the arrangement of the deltoid fibers, and so you have to translate the upper part of to sweep the upper part of the probe from A to B when you go to examine these fascicles from posterior to anterior. You have to progressively move the top of your probe from A to B. Remember, this is the trick of the trade to see this ligament better than normal. Then for the posterior part of this ligament, the tibio-talar component, you have to dorsiflex the foot. And this is easily conceivable because in dorsiflexion you can make this part of the deltoid in tension. So this is the tibio-talar ligament, and the tibio-talar is very, very thick. It's located just deep to the tibialis posterior tendon. Use the tibialis posterior as a landmark anytime you check the different components of the deltoid. And deep to the tibialis posterior, we have the superficial part. You started to see the superficial part formed by the most posterior fibers of the tibiocalcanear. If you go more anteriorly, you see the tibiocalcanear more clearly. This is medial malleolus, talus, and calcaneus. And this is the second fascicle of the tibio-talar ligament located connecting this area. The tibiocalcanear is superficial. This is the beginning of the tibiocalcanear. Then it becomes thicker and thicker, going more anteriorly. Remember to move the probe this way, so even the top of the probe, because if you wanted to have a well depiction of this component of the deltoid, the probe needs to be really more anterior. And if you go even more anteriorly, you can see the continuity of the same tibiocalcanear with the tibiospring. And the tibiospring is this one. You see the ligament joining the medial malleolus, then continuing into a ligament. It doesn't attach into bone. It is superficial to bone, and this is the spring. This is again the posterior tibial tendon. So this is the spring, this is the position of the tibiospring, and finally the tibionavicular. Eversion is very important to image the most anterior part of the deltoid, and also plantar flexion may create some tension in the ligament. The last ligament, the tibionavicular, is visible not in any case. You can see the proximal origin so nicely in general, but more distally the ligament is very thin, and if you don't have a perfect probe and a perfect patient, it's not visible. But remember that in many cases injuries occur cranially and not more distally. So remember that the medial ligamentous complex injuries account for approximately 15% of ligamentous ankle trauma. They may be associated with a lot of other conditions. In an isolated form, they are really rare, and they may produce medial ankle instability, especially at the level of the talocalcaneonavicular joint. So the tibio spring and the tibionavicular, this is not really known, but the most commonly injured, or at least this was reported in literature. And in general, the proximal tear is the most common occurrence. The distal tears are much more uncommon. This is the involvement of the tibionavicular in at the level of its proximal part. You see the swollen and heterogeneous tissue at the level of the ligament. This is an avulsion injury at the level of the talar insertion of the tibio-talar ligament. Here is another partial thickness tear of the tibio-talar ligament with a swollen tibio-calcanear component. Anyway, if you are systematic, you can identify the component, the involved component, and you can also be very accurate to assess the status of these structures. Don't forget the spring. The spring is a very complex structure forming the medial wall for the talar head. So it completes the socket because the joint surfaces represented by the talar head and the navicular, this is the articular surface of the navicular, the navicular is smaller compared to the talar head, and so the socket to contain the talar head needed to be completed by the spring. The spring, remember, is complex because it's made of a supromedial component visible here, and this is the component that we see on ultrasound. And then there is a medioplantar and an inferoplantar oblique. Here is also the site of the vein of the plantar calcaneocuboid ligament. So one component is visible. Remember that it contains a lot of fibrocartilage, and you can understand by checking these images. So it's not really a spring. It's not elastic. The spring ligament, but is a very strong structure to support the talar head to stabilize the longitudinal arch of the foot. And in case of insufficiency of this ligament, you have a plantar flexion of the talus, a valgus alignment of the calcaneus, and flat foot deformity. So how to image this ligament? You have to place the probe at the level of the substentaculum, and the probe has to point more cranially, anteriorly. Again, which are the landmarks? The tibialis posterior tendon superficially, and deeply you can see the joint between the substentaculum and the talar head. The talar head forms some convexity here related to the head, and in many cases you can also see some cartilage at this point. So this is the long axis of the spring ligament. Where to measure the ligament? You have to measure here just deep to the tibialis posterior, and then also in a more advanced, in a more anterior location. Which are the signs of ligament insufficiency: thickening of the supromedial part with a more heterogeneous ecotexture, loss of the fibrillar pattern. If you switch color Doppler on, you can also see a hypervascular pattern at the level of the ligament. So there is a nice study published in literature showing that in cases of symptomatic people with ligament insufficiency, the ligament appeared swollen than normal, and this is a case showing the discrepant size of the ligament by comparing the affected side with the normal contralateral side. And when you check the spring ligament, you also perform the examination to rule out this is what happens normally to rule out a problem of the tibialis posterior tendon. No, you expect to see a problem in the tibialis posterior. In many cases, you see that there is a degenerative tendinopathy. Remember that when you see an abnormality affecting the tibialis posterior, you have to spend some seconds more to go to check the spring, because the spring may be involved in association with the tibialis posterior tendon disease. So this is very important. Go and check systematically the spring, of course, in cases in which you have abnormalities affecting the inframalleolar portion of the tibialis posterior. And of course, if you have any doubt about that, MRI may solve the problem. You see the sprain of the spring in this image. Thank you very much.